So we know from clinical trials and from registries that patients with CLL, their major risk is actually to die from an infection, or to suffer from serious infections with significant morbidity. So what is the focus in a number of different studies, both using laboratory assessment based on translational samples from clinical trials, but also using registries and long-term follow-up, is to try to identify these group of patients that have a higher risk of suffering from immune dysfunction. When we look at clinical trial cohorts, we aim to use translational studies on biobank samples with immune phenotyping to identify the patients that would have a larger chance of not having an infection after receiving treatment as compared to prior to receiving treatment. That's because we want to define if different types of targeted treatment or even chemoimmunotherapy would have a different impact on the immune dysfunction and the risk of infections. We have seen preliminary data on some of these immune phenotyping tests where we can actually demonstrate that the immune function is improving over time on treatment both with BTK inhibitors and BTK inhibitors combined with BCL2 inhibitors. This has led to our current trial, the PreVent-ACaLL trial, where we use machine learning methods or models, essentially recognizing patterns based on routine data to identify patients, treatment-naive patients at time of diagnosis of CLL that might have a higher risk of serious infections, and then we randomize them for between a treatment, short-term treatment, just 3 cycles of a BTK inhibitor and BCL2 inhibitor, or observation, which would be standard of care. So this is the focus, to use what we see in the laboratory from immune phenotyping biobank samples from patients receiving targeted treatment to actually implement an intervention that could improve the immune function for patients and reduce the risk for them of suffering from serious infections.